fairly soon. Everyone's happy? Yeah.
Yeah. Mm-hmm.
Okay. Which isn't they should be starting fairly soon. Which isn't they should be starting fairly.
Right, do you want to start now then?
Okay.
Want to start? Hello. Right, are you ready to start now? Yeah?
Okay, Jonathan?
Yeah, okay.
Okay, let's go for it.
Okay. Thank you. Good morning, everybody. I'm Jan Short, General Secretary of the National Pensioners Convention, and I would like to welcome everybody to this debate today on International Day for Older People. And on this day, I think it's only right that we remember all those across all generations who lost their lives to COVID-19, and to pay tribute to the heroes in frontline services who gave their lives working and caring for others. We have a panel of speakers, a number of guest speakers from across a range of political and professional backgrounds. We also have with us members of the Health and Social Care Working Party, members of NPC from various parts of the country, representatives from the press, and the event is also being streamed and recorded on YouTube. So welcome to you all. This is a new venture for us as Older People's Organisation, and I'm hoping that the gremlins that usually reside in technology will have taken the day off. So bear with us, and together we'll have an informative, open debate. Helping us out today are Jonathan, our Information Officer, and Bev, our Campaigns Officer, both of whom have worked extremely hard to get this off the ground. And I would like to ask Jonathan to go through how it'll all work, how you can ask questions and all the other bits and pieces of technology. So Jonathan, thank you.
Hi there, I'm Jonathan Safer, the Information Officer for the NPC. As Jan said, hopefully this is the first of many webinars that the NPC can put on, and I would ask for your patience, and hopefully technology is kind to us today. We've received a fair number of questions already to both our panelists and our guest speakers, but I would ask the attendees that if you do have any questions as you go along, at the bottom of the panel, you should see Q&A, and you're able to type your questions at the bottom. Please give your name, who the question is directed to, and we will try and get it answered. As I said, we have received a number of questions, so if we aren't able to get round to your specific question, we do apologise, and we will try and answer it at a later date. If there are things during the event that you're unsure of, you can just, as I said, use the Q&A, and there will be specific points where we'll get the panelists or the guest speakers to answer those questions. Okay, over to Jan. Thank you.
Thank you, Jonathan. And I want to introduce the main panel of speakers that will be alongside me. First of all, we have Professor David Oliver, who is a visiting fellow, King's Fund, and NHS consultant in geriatrics and acute general medicine. Welcome, David. We also have Dr. Jean Hardiman-Smith, who is the chair of our NPC Health and Care Party. Hello, Jean.
Good morning. It's
Yeah, I have
to be here.
I have a set of apologies because we did ask an awful lot of people to join us. So we have apologies from Sir Ed Davey, MP, leader of the Liberal Democrats, Lord Fuchs of Conmuck, Angela Rayner MP, Deputy Leader of the Labour Party, the Right Honourable Jeremy Hunt MP, Chair of the Parliamentary Select Committee on Health and Social Care, Liz Kendall MP, Shadow Minister for Social Care, Meg Hiller MP, Chair of the Public Accounts Committee, Sarah Pickup, Deputy Chief Executive of the Local Government Association, Caroline Lucas MP, Green Party, Mary Ann Stevenson, Director, Women's Budget Group, and unfortunately Baroness Sally Greengrass has just had to pull out due to parliamentary business, which of course we do understand. But we will be inviting these and a variety of others to future events. And for those MPC members watching or listening in, yes, we did invite ministers from the Department of Health and Social Care to this debate, but as is usual, no response has been received. We know everyone is busy at the moment, but our invited guests have made this event a priority, and there are numerous people in the department who could have been asked to attend in the minister's absence. But we will continue to invite them to future events because these are the policymakers and decision makers, and they should be engaging in events like this that are asking difficult questions, but also positively promoting solutions. Now, before we start going into the panel presentations, we'd like to play you a video which actually sets the tone of what this debate is all about.
Last few weeks, it's been hard, really hard. It's like an emotion, you know, you're up and down, you're caring for people under the hardest conditions. To see people get so sick and so poorly and only be able to hold their hand, not be able to give them a cuddle, not be able to do my job, it makes me feel frustrated inside.
They were dropping like flies, the residents, staff were on self-isolating, and we thought that we were going to have a complete wipeout.
This is people's parents, aunties, uncles, grandmas, granddads. Why are they forgotten about? Assuming.
I felt like I was losing every day. It was really hard. It was really hard. It affected me. It affected me really emotionally. And I didn't know if I could keep it up because there was just too much responsibility at one point.
We're seen as low paid, low skilled, but you need to be really skillful, and not everyone can do a care job. So to put us in that bracket of being low skilled is just completely ridiculous.
I remember myself saying that I'm just a carer, like it was a nothing. But you know, high paid earners can't do what we do. And I think we need as much recognition as we deserve, because we have done a job way and above what a carer has ever experienced or had the skills to do, but we did it. And we hope and we pray that it doesn't come back again.
Because I just want things to go back to normal. You know, we're struggling, we're so tired, we're forgotten about. You know, we've been left. I know there is really ill people in hospital, but we've had really ill people here as well. We've been like a little mini hospital.
It's only just recently, in the last 2 weeks, we've been able to test residents. We should have had that from the start. We should have been able to have testing on staff straight away. We didn't get that straight away. You have to have a car to be able to get to the testing site.
Right at the beginning, we should have had support from a practitioner. How are things? What do you need? What can we do for you? Do this, advice. We didn't get anything like that.
The emotional impact, I go home every day and I'm crying because I don't know if a resident could have had COVID or a resident has died from it who I was quite close with.
I've broke down a few times where it's been overwhelming having such responsibility of lives. With regards to the team, it's brought so many staff much more closer together. And I think, I mean, I have to commend on the staff. They've been amazing.
Sorry.
So back to Jan.
Yeah, let's continue with Jan.
Okay, thank you. Not the best of technical crunches, but there you go. I think the flavour of that actually encompasses what we're here to talk about today. So we can see from that video just how hard it has been for those working in care homes and also in care at home situations. The message from St Ives will be echoed in the country as we move closer to winter and the prediction of a second wave that may be worse than the first. Goodbye Cinderella is a culmination of just over 2 years' work by the NPC Health and Social Care Working Party. For decades, our members have been arguing for change because of the unfairness in which care is provided. We surveyed our members, asking them what they would like to see as a high quality care service and who they wanted to deliver it and how. Their responses guided us towards a national care service, free at the point of need, funded by taxation, with the individual at the heart. The resulting recommendations have been widely consulted on with the NPC through its democratic structures, and despite lockdown, we were able to launch the booklet in June this year. It felt absolutely the right time, whilst we were hearing the most awful stories about the devastation in care homes and the ability to carry out care at home services. The fact that we were so unprepared for this pandemic lies squarely at the feet of this and the previous government for a decade of chronic underfunding and privatisation. With 85% of care being delivered by private providers and around 1.4 million people unable to get any kind of basic care, it was only a matter of time before the system collapsed. So why a national care service? Because there is such unfairness in the way in which care is funded, or not, as the case may be. It is another form of postcode lottery. The main cause of the unfairness is successive governments redefining the health needs and conditions of older people, taking them out of the NHS, which is free, and moving them to social care, which is means tested. Means testing is an archaic, costly, and unfair way of deciding who should get what service. A national care service would be a universal service, publicly funded, publicly delivered, and publicly accountable, with a robust, independent regulatory and monitoring unit, overseeing national quality care standards, as well as a nationally accredited training for all care workers. And although Goodbye Cinderella has been written for older people, by older people, it is a blueprint for all ages. It also takes account of generational fairness, a topic which is regularly used to instate conflict between generations. But a national care service alone will not sustain improved health of our citizens. Far too many are living in non-decent standard homes across the country. It is well researched that hard to heat, damp, cold homes are dangerous to your health, costing the NHS £1.4 billion a year. Investment in long-term housing needs of older, vulnerable people is much needed, as is the important improvement of substandard homes across the country for all generations. The NPC has also asked the general public if they would agree to an increase in income tax and national insurance contributions to ensure that everyone can access care when needed. An overwhelming majority said they would, but expected that the government would ring-fence the extra income and only spend it on care. The Daily Express also ran a survey of their readers, and the answers were the same. Today's event is the beginning of a wider debate that needs to happen with the government, being open and honest about what the public can expect, and stakeholders being given opportunities to challenge policies that are discriminatory, unfair, and unnecessary in what is still one of the wealthiest countries in the economically developed world. Thank you. Can I now ask Dr. Jean Hardiman-Smith for her presentation? Thank you, Jean. We have a problem with the sound.
If you just unmute your microphone, please. Thank you.
Yeah. I would like to pay tribute to the National Pensioners Convention Health and Care Working Party members. The people involved are passionate about care, hardworking, and while they may hold different views and perspectives, they hold each other in esteem and friendship, enabling us to formulate a cohesive team perspective we can all get behind. It is a privilege and joy to work with you. I would like to talk about care and a little bit about money, mostly informal and family care as an expert by experience, since my parents were carers when I was born and continued to do so until I became their carer. I now have a carer of my own, having multiple disabilities. What I have learned is that increasingly carers, particularly pensioner carers, are effectively being abused physically, financially, and mentally. They are expected to make up the shortfall in the workforce and lack of funding out of their own goodwill. They're performing heavy living tasks, administering medications, and even taking over nursing duties. My husband delivers 5 injections a day to me. Supporting, training, and properly paying the formal workforce would relieve some of the burden and be a huge boost to the local and therefore national economy if done correctly. Financially, pensioners are not entitled to a carer's allowance, and for the majority, part of their state pension is not even ring-fenced. With more pulls in their purse and less money, they are increasingly financially vulnerable, leading to stress and less input to the economy and a less efficient and perhaps even abusive caring. Mentally and physically, caring can take place 24/7, 7 days a week, with little respite unless they are offered it or can afford it. Carers' mental and physical health suffers, leading to burnout. This is both nationally and from an American perspective, it's pretty much the same. The pattern is the same. In America and here, it's typical for one person to do most or all of the caring work. Local authorities are both staff and financially increasingly poor, with a postcode lottery that likely will result in the most needy cases and people getting the least of both services and funding. And this is actually an economic drain. The paid workforce should be properly registered and trained with portable qualifications. Caring is complex and responsible role, and moral esteem must be lifted and properly reflected in pay scales. It should be something that our young people consider as a viable career, and carers' input, formal and informal, would give them a huge boost, would give local economies a huge boost. Finally, respite could be provided and informal carers supported formally, and that would help relieve some of the pressures on informal carers. The current system is feeding in more frail and elderly pensioners and simply adding to pressures on the nation's health, well-being, and economically. After COVID, carers are suffering from lost, carers, formal carers, are actually beginning to suffer from post-traumatic stress disorder. It has been such a burden on them, such a strain. This cannot be allowed to continue. I believe modern monetary theory shows we operate more like an interdependent village, and taking money out of the system by pulling on the purse strings. Well, your local shop stops trading, your daughter loses her job, and your household has less money. A self-replicating downward spiral. Caring is one opportunity for the nation and the government to break this cycle at a time when this is crucial. This is in all our interests. Thank you very much.
Thank you, Jean. We now turn to Professor David Oliver to do his presentation. David?
Okay, I hope people can hear me all right. The sound's been coming in and out. I don't have any slides, but I am cheating a bit by reading a computer screen behind my computer screen. So if I've got a faraway look in that on my eyes, you know why. I'm a doctor in the NHS. I've been one for 31 years, consultant for 23 years, and I look after acutely ill adults and older people for a living. And I've played all sorts of policy and leadership roles beyond doing the clinical day job. In fact, my own father was 78 last week, and he also spent his working life as an NHS doctor and in the second half of his career looking after older people. And I was thinking that although my own parents are both in good nick at the moment, I've certainly had family members who have been carers or have required care, and this touches not just older people, but adult children who end up having to support their elders. I'm sitting in an office at the moment on a hospital ward that's got a median age of 84, and I guess probably 2/3 of the people on there have some social care needs or contact with the social care system. But I'm also a friend of the National Pensioners Convention, and I've spoken at the Winter Gardens 3 times over the past few years, and I wrote the foreword for the Cinderella report. But I was also the president of the British Geriatric Society, and there's a little quote that's in the main body of the report from the NPC from 1997, where the BGS set out what good looked like, and it's worth revisiting because it's still what we're talking about now. And the quote is that we should enable older people to lead as full and independent a life as possible as active members of the community, provide comprehensive health and social services to support people in their own homes, ensure dignity is preserved and distress minimized at all times, and ensure training and high professional standards are established and maintained by all staff. And before I go any further, I must acknowledge, because people will pick us up on this, that not all adult social care is older people. There's a significant provision as well for younger, physically and learning disabled adults. But I do realise the focus of the NPC report is on older people, and that's about 71% of all requests for social care support and over half the spend. As I say, I do work in my day job very much at the interface between health and social care. I see people coming into the acute hospital front door who've had struggles at home. I see people from care homes. I send people to care homes, and I discharge people who require packages of care. And we have several colleagues. We have colleagues in my local team who spend most of their time working out with community teams and care home staff. And one thing I see all the way through my working week is the unseen work of unpaid family carers, who, we must remember, provide the majority of care in this country, and often have very little support, and they're often older people themselves, and often their own health is affected by the role. But I've also lived with the policy debate and the service changes over the years in my time working in the government and in professional leadership roles. I've seen a question coming in, by the way, saying, can we get transcripts? And I'm quite happy to ping my notes around afterwards if people want to see them. One thing I would say is that the coronavirus pandemic has definitely accelerated some of the structural problems in the service, but it's also brought into sharp relief social care. It's tended to be out of sight, out of mind, unless you find yourself having to use social care services. And whilst most of the public have some decent understanding of what the GP does or what the local accident and emergency department does, it's often a surprise how social care functions differently, and a shock at times of great stress often that people are up against, navigating the complexity and the disjointedness between health and social care, and the fact that it's means tested and eligibility based and rationed as opposed to free at point and based on need. So it has for too long been a Cinderella service, and it goes well beyond care homes, which I realise have been the biggest focus of media coverage recently. It's also around prevention and housing and adaptations and support for independence, and of course home care services. But I haven't forgotten Boris Johnson's pledge. I'm sure you'll remember this in the Queen's speech before the pandemic, that he was going to find a cross-party lasting solution to social care by January next year. I can't see that happening, but that, of course, was the latest of many ducked opportunities going all the way back to the Royal Commission on Long-Term Care in the late 90s and the more recent Green Paper. Just to give you an idea, though, there's some triangulation between what the NPC are arguing and other commentators. I'm going to read you 8 bullet points from Simon Bottery, who leads a lot of the King's Fund's work on social care. And he wrote about the 8 biggest challenges, and then he's reviewed that recently, showing how the coronavirus pandemic has brought them into focus. So here were Simon's 8 points. Means testing, because social care is not free at point. Catastrophic costs for some people, because unlike other public services, we don't have risk pooling and shared risk, which Dilnot also showed in his 2011 report. Unmet need. We know there are large numbers of people whose needs are low or moderate, who are not getting their care needs met, lots of carers without support, and there are fewer people now in receipt of social care than there were at the 2010 election. There's the quality of care, which is very variable and sometimes rushed. Workforce. The social care workforce is actually larger than the NHS workforce, and around 1 in 8 vacancies are unfilled, and about 1 in 5 of the social care workforce are from overseas. Social care is not in the NHS people plan, the workforce plan, and until a slight recent pulling back, social care workers aren't really covered by the new immigration rules around key workers. There's a fragile market with a lot of providers struggling to remain viable, and self-funders often cross-subsidising people who are council funded. Disjointed care between health and social care, including these rather arbitrary rules about what counts as health and what counts as social, and a so-called postcode lottery. So if I move on from what Simon said to what the big asks are, in the NPC report, there's a remarkable similarity. There's a call for a national care service with national entitlements, albeit with a strong focus on local delivery, because social care is personalised and local, and we don't want something monolithic. An adequate funding settlement which enables people with low and moderate needs to be met, greater use of general taxation, an end to the bewildering and arbitrary rules between which conditions count as health and social. For instance, we've effectively labelled dementia as a social care condition, whereas cancer is a health condition. And that's bewildering to me, and it's more bewildering to the public. Means testing and rationing need to be swept away. Far closer collaboration between health and social care sectors, because it's the same people with the same needs, and there are some arbitrary divides. A greater focus on prevention and planning. And I think a key element of the NPC report is on better training and registration and standards and career development for the workforce. One of the justifications in the immigration rules around the care workforce is that they're not paid well enough, and even people coming in from overseas don't tend to stay in the sector. There's around a 30% annual turnover in care assistant roles. We need to make it a valued, attractive career with development opportunities, because this is not basic care, this is actually skilled care that's crucial to people's lives. Better focus on quality and inspection, which has been largely suspended during the pandemic, and a return to more public sector provision of services. At the moment, about 80% of provision is from the market, and most of the rest is from the voluntary sector. There is that rump of care, which is still NHS funded, continuing care, but more public provision. And the big thing as well is more support for those unpaid family care carers as opposed to professional care workers. And I think the NPC report offers a roadmap for change worthy of serious consideration. And if you see what the health policy think tanks and some of the other lobbying and campaigning groups are saying, they're all on roughly, give or take, the same page. So now is a time for action, pandemic or not, and to hold the Prime Minister's feet to the fire for that pledge around sustainable cross-party solutions by next year. Thanks for listening.
Thank you, David. Thank you very much. I need to put 2 extra apologies into the ones I gave before, from Caroline Lucas, MP from the Green Party, and from Mary Ann Stevenson, who is director of the Women's Budget Group, who have very interestingly done some research on how investing taxpayers' money into social care creates a good, better economy. And obviously we'll be happy to see them at one of the next events. I think it's important for people to understand where the money is going and how it can be better spent. Yeah. Now, I'd like to introduce our guest speakers. Jonathan will come in by one as I read your name out, if you're on screen. So Nadra Ahmed, OBE Chair, the National Care Association. Hello, Nadra.
Hello, hi, good morning.
Are you okay?
I'm good, thank you. Yes,
Thank
and
you.
fascinating
Thank
just
you.
listening to that presentation by Dr. Oliver. Just, oh, can you hear me at all?
Yeah, we'll be taking some comments afterwards, Nadra. So if I just introduce all the rest, and then we'll go through what,
Sure.
you know, what people want to comment on and ask questions on. So thank you. Dr. Crystal Oldman, CBE, Chief Executive of Queen's Nursing Institute. Hello, Dr. Crystal.
Hi.
How are you?
Thank you very much for inviting me today.
You're
Really,
welcome. Yeah, you're welcome. Sharon Hodgson, MP, who's the Shadow Minister for Veterans. Sharon, are you there? She was a minute ago.
Was a minute ago.
It was a minute ago. She is probably nipping in and out because I know she's got business. She needed to join late and will need to probably leave early, but she will be with us, I'm sure, for the real thing. Professor Dame June Clark, Professor Emeritus of Community Nursing, Swansea University, Board Member RCN Wales, and also a very valued member of the NPC Health and Social Care Working Party. Hello, June, how are you? You're on mute. Right, hello.
I'm better now.
Yeah, okay, thank you. Mary Robertson, Senior Policy Officer from the TUC. Mary?
Hi there.
How
Thanks
are you?
for having me. I'm very well, very pleased to be here.
Good. Councillor Kilgour? Karen Kilgour?
Hello, good to be with you today.
Karen, are you with us?
I am, good to be with you. Sorry, I'm down as Philip Mann on the screen, but I'm not. I'm Karen Kilgour. Good to be with you today.
Okay, we'll see what we can do. And Dr. Aaron Baxi, who's the Emeritus Consultant Physician at St Mary's Hospital, the Isle of Wight. Hello, Dr. Baxi, how are you?
Good morning. Thank you for inviting me.
Good, you're welcome. Okay.
And sorry, just to interrupt, Sharon Hodgson, MP, has just joined us.
Oh, right, Sharon.
Hello, good
Hello.
morning. I didn't think I thought you'd missed me there, Jan.
I hadn't missed you, you just weren't showing up on my screen.
Ah, right, no, I'm here.
Yeah. Hello, and how are you?
I'm very well, thank you.
Good, thank you very much. So that's the introductions done. Everybody has been introduced and we know who they are and what they do. So we've got some questions, I understand, Jonathan, from or some comments from the presentation. So the ones I've seen, I don't know why my thingy's not working. There it is. All right. Yeah, there is a comment here from a lady called Violet Rook, and it's quite absolutely appropriate, and I think David and Jean would both agree with this, is it not the economic system which encourages the idea of the market and promotes private care? So what she's saying is the idea that the market will deal with all of the issues that need dealing with. There's a comment here, as a long-term carer from Martin. Long-term carer, I find healthcare professionals struggle through pressure of work, cuts to involve carers in service user plans. And I think we would absolutely agree with that. Another one, care workers do the work of nurses. How can those in control be made aware of the work processes involved? Yeah. And a thank you from Shirley McGrath, who is an old friend of mine. So they're the comments. Does anyone want to, from the panel of guests that we've just introduced, and I think it was you, Nadra, that had a comment on the presentation from Dr. Oliver?
Yes, thank you very much. I mean, it was a presentation that I would have given myself, really, because it picked up on all the points. So thank you for that. And I suppose the question that I would have is really centering around how a model of integration might work, because we're really concerned as social care providers when we consistently hear about the integration of health and social care, because as things stand, social care is so easily marginalised in every form. How would an integrated model make it any better is my kind of thinking and question, really.
Right, Nadra, I think one of the things that the NPC booklet shows for a national care service doesn't actually promote total integration.
Good.
What it promotes is joined up working, between the NHS and local government. What we believe is that to integrate, as you say, those disparate of a service damages the budget system. It enables government to make budget cuts that they wouldn't normally make because they're hidden under that integrated package. We understood that from Northern Ireland. They jumped straight into an integrated care system on the promise that the government would fund it. The promise that the government made didn't come to fruition. They got a whole lot less money than they were promised, and it is now completely going the way that the English is. So we wouldn't promote total integration. It is about a joined up working. So as David said, based locally in the community. So you've got one person who has maybe got multiple conditions and needs healthcare as well as what they term social care at the moment. But they have something wrong with their health, they have to go to hospital, but they also need care in their home or in a care home. So there'll be a team of people around that person working with that person together. So because what we find is that some medication doesn't suit other medication. And if people are working together around that person, they can actually be part of the care package, be part of what is delivered, and they can also control how it's delivered and who by. So we're not advocating total integration because we know that won't work. Does that answer your...
Yeah, it does. And I think it's more aligned akin to what we think, which is this sort of pathway that follows the individual rather than a system that you have to fit into. So it's about making sure that whatever the assessed needs of any individual are actually the ones that are met through a variety of faceted services, whether they are within the local authorities or the NHS or the so yes, it does fit in much better because that's our fear. Our fear is always around people fit into systems, and then you kind of get the unmet need scenarios, which I think is a real source of concern, because there are an awful lot of people whose needs aren't met because they don't actually fit into a system.
Yeah, and that's
Can
why.
I make a comment?
Yeah, just a minute, Joan.
Okay.
I just want to answer that, yeah. And I think that's why we did not go for full integration, because there are, you know, when you integrate services, you always lose something from each of the services that are pulled together. And as you say, there are people with very, very different needs. Every single person, you know, they may have the same condition, they may have heart condition, but the way that it affects that individual is different all the time, and different medications. So we wanted to make sure that the individual was at the heart of the delivery, and that delivery was connected and joined up. Yeah. Sorry, June, you wanted
Yes.
to make...
I'm June Clark, and my background is in nursing. I was a member of the Royal Commission on Long-Term Care all those years ago. I wanted to pick up 2 points, and please, Jan, if you've got them scheduled for later in our debate, tell me and I'll keep them from them. The first one is the point that was made by the first question about the effect of the market. When I get to my bit, one of the things I want to talk about is how Wales differs from England in many ways that have impacted both the general provision of personal care and the COVID arrangements. And it is that if you use the example, as I was going to, of test and trace, in Wales, this has been organised within the NHS. Public Health Wales is within the NHS, and we believe this is right cross-party, right across the board, that healthcare and social care are public services, not a commodity to be bought and sold. And so that in our NHS structures, for example, we do not generally outsource to other countries, whereas the England system, especially in relation to test and trace at the moment, the fact that it's been outsourced to multiple private enterprise providers, many of whom, whatever the suffering of people who are suffering it, many of whom are making a bomb out of public money. And I think that there is a lesson to learn there about what you can outsource and what you can't outsource, and what you have to do if you do outsource to control what's done. On integration, this may come up again later. I think I agree that we cannot have wholesale structural change, but over the last several months now, several areas have integrated parts of their service. One of my particular, and it is personal, I stress that, things is because there is so little difference between the personal care provided by social services carers and the fundamental nursing care, as they call it. It's just a different name that is provided by the community nursing service, that those two could merge and could be, so that many of the carers could have the better pay, better conditions. They're not wonderful, but they are better, that are available to nurses, for example, in the NHS. There are good models of partial integration that we could use.
Yeah, okay, thank you, June. Thank you. Need to move on now. There will be opportunities for questions later on. Now, we move to our guest speakers, and Nadia, we're coming to you first. Okay. The question that we pose to you is, what are the main challenges in care right now, and how is it failing carers and those being cared for? What do you think the solution is? You've got literally 5 minutes.
Okay, no big task then.
No big task.
I mean, obviously, with COVID and the pandemic, the challenges have have been heightened, if you like. Now, the issue for us is not a new one. The funding of social care has seen many iterations of commissions over the years. And so we know that the funding of social care needed to be resolved. And of course, the two main things are funding, but even more importantly is our workforce and how our workforce emerges, is perceived and is rewarded. So I think those are the kind of challenges that we carry with us and have done for certainly the last 2 decades, with no government having the gumption to actually deal with it, despite the many promises that get made on the steps of Downing Street post-election. So I think those are really challenging things. And so when we've come into the pandemic, and the question about right now is about having the right tools to support the people that we care for. We are looking after some of the most vulnerable people who should actually be shielded, and they should have had that ring of steel, which is a vision that was never really in the making or emerged in any way that was visible to us anyway. So we were left as an afterthought. And I think that has lived with us, and the impact on our staff, their mental, their physical well-being, and the anxieties that it's created for what might be around the corner for us if there was a second wave. I think those are the challenges we face. The lack of PPE at that time still lives with us. And despite the announcements about free PPE, the devil's always in the detail, and it'll only be an element of the PPE that's free. But it was a very good headline, and we're grateful for whatever we're able to get. We've got testing, which, you know, we didn't have then, and we were crying out for it. Massive issue then, still a massive issue now. In the last 3 days, I've started to get some more positive vibes about people telling me that they are now getting the tests coming into care homes. So despite the fact in July we were told that everybody would have a test who needed it, I've had providers who've not had tests, either for the staff or for the residents. But that is improving. And now the bigger challenge is the turnaround time of getting those tests in place. In the winter plan, we've also seen this really challenging moment of the discharge from hospitals, which we know was one of the sources of transmission. We also know that obviously movement of staff was the other, and we're trying to mitigate that. Not many providers are very keen to use agency staff, but if you've got 30% of your staff off self-isolating, you may be challenged not to be able to do that. And I know there are things that are in progress. I'm very worried, I'm very concerned about the announcements that have come through the winter plan that are talking about the discharges into facilities and how that might work. So I think we need to put that you know, what wasn't there before, but if the time is right now for that ring of steel to be around the sector. We've got some real viability issues. Provider failure is around the corner. People understandably don't want to choose social care as somewhere where they go. And of course, staff are beginning to think twice. I've had numerous conversations now with people telling me they've had resignations, and of very senior staff who've had to take that pressure. You know, being called, totally being undervalued, being called unskilled when they are the ones, you know, in a hospital setting, a nurse will give you your medication during the drug round, but in our services, we train our staff. It's just one example to give out the medication. These are very skilled individuals. To have that eliminated, and then to be told by the Home Office that actually, you know, the route of the migrant workforce needs to be closed because we've got a tranche of people who have unfortunately left their jobs or lost their jobs and can move into the social care sector, it just doesn't work like that. The domestic workforce, because of the image of social care, don't come forward. We don't have a register. We don't have a qualification agenda. We don't have a career pathway. These are all things that we've been promised over and over again. And the sector itself moves that forward. Most of them don't pay the national living wage. They pay above the national living wage. They may recruit to the national living wage. But then once you've got people trained, you've got to recognise that. And of course, the last thing that I might want to say in this is that local authority funding is abysmal. I represent the small to medium-sized providers. So these are individuals who've got bank loans themselves, personal loans themselves. I know of providers who've now told me that they've had to cash in their pension schemes personally because of what happened with COVID and what they paid for the PPE. So people are in huge debt now, and there's been no funding that's come forward for that to support providers. So I think we've got those real challenges where there are voids. People don't want to go into care services. So the viability of those services will struggle. And how do we move forward when we've got staff group that's very fragile as well? And we need to support them to show them that it's a career path.
Nadia, can I ask you to wind up there, please?
I'm done. I'm done.
You're done.
I'm done. Sorry, I'm trying to.
No, this is a passionate subject, and want to give as much time as we can, but I'm conscious that time is not doesn't wait for us. Sharon Hodgson, you're next. Shadow Minister for Veterans. Sharon, your question we gave you was, what's been your experience both as a Shadow Minister for Veterans and an MP of the impact of a failing care system? Is the National Care Service the answer?
Thanks, Jan. And hello, everyone. It's really great to be on this webinar today and with you all covering such an important issue. As you have probably heard, I'm Sharon Hodgson. I'm the Member of Parliament for Washington and Sunderland West. Some of you will know my fabulous constituent, Norman Jemison. And I'm also, as you heard, the Shadow Minister for Veterans. So, as I'm sure we've already heard today, the care sector really has been at the forefront of the battle against coronavirus. And as the new report from the National Pensioners Convention highlights, the pandemic has laid bare the urgent need for change. And for too long, social care has lacked the priority and attention it deserves, and we all know that. And I truly believe that long-term reform is essential. The outbreak of coronavirus and its spread throughout the country has demonstrated beyond all doubt just how important social care is. And I know the difficulties that some of my care homes went through, and I know how tough it has been for them. So I want to start by paying tribute to the extraordinary efforts of care workers, as well as NHS staff and key workers who have gone the extra mile to care for older and vulnerable people, and they deserve our respect, admiration, and full support. And it's just not good enough to have clapped for them during the worst days of this crisis without undertaking a serious reckoning around pay and treatment. Unfortunately, as too many people will know from personal experiences, mistakes were made at the beginning of this pandemic, and the government was far too slow to act to protect older and disabled people. A report by the House of Commons Public Accounts Committee has found that care staff were left without protective equipment. Thousands of older people were discharged from hospitals to care homes without tests, and ministers did not ensure that social care was given the focus it needed. And as Shadow Minister for Veterans, to answer the question, I'm angry that an entire generation was put at such great risk, many of whom will have fought for our country or lived through some of our darkest days. And as the leader of my party, Keir Starmer, wrote on VE Day earlier this year, we owe it to the VE Day generation to protect them from coronavirus in care homes. And I know that our social care sector has been underfunded for far too long, and it was ill prepared to deal with a public health emergency like coronavirus. The Association of Directors of Adult Social Services, ADAS, estimates that following a decade of cuts to local government, more than 8 billion has been lost from adult social care budgets since 2010, 8 billion. and too many people have been left to cope without the support they need consequently. That is simply not good enough. And a report commissioned by the Local Government Association and ADAS found that adult social care providers and councils face up to 6.6 billion in extra costs as a result of the coronavirus emergency. So 8 billion's worth of cuts and then 6.6 billion in extra costs. It's just impossible to manage those numbers. So alongside my Labour colleagues, I will press the government to ensure that social care providers are compensated for the additional costs caused by COVID-19. Beyond the pandemic, long-term reform of the social care system is urgently needed. And I believe this is vital to ensure increase access to care, to help the 1.5 million people currently going without the support they need, and to protect people from high care costs. I also believe ministers should address the widespread vacancies across the social care sector. They should invest properly in the workforce and support unpaid carers. So in closing, at the last general election, I was proud to stand on a manifesto which pledged to build a comprehensive national care service. And I note again with great interest the case made for one in your many reports over the years, including the latest one. I've personally always supported your calls for this, as I'm sure you know. And although it's not my brief, but I will certainly fight your corner again as the issue is discussed in the coming months. So once again, thank you, Jan and the NPC, for inviting me to speak here today.
Thank you, Sharon. I know you need to leave a bit quickly for 1 o'clock. We do have some questions from NPC members, and there is one for you. If you're not around, we'll write to you, and perhaps you would be good enough to give us the answer. But thank you for your time today. Thank you.
I'll stay as long as I can, Jan.
Thank you. Next is Dr. Crystal Oldman of the Queen's Nursing Institute. Hello, Dr. Oldman.
Hi.
Hi.
Hi, thank you. Thank you, Jan. Thank you very much for inviting me today.
You're welcome.
And thank you very much for my questions. I think there are two there actually.
Can I just read it out so that people who are not on video, we've got some people who are not on video. So if I just read it out, Crystal. The question is, how important to improving the quality of care is parity between care workers and NHS workers? And the NPC actually thanks the Queen's Nursing Institute for their research on DNRs. And we have had a question on DNRs whilst we've been talking. But should those put in place in the first wave of the virus without consultation be rescinded before the predicted second wave? Sorry. Okay, Crystal.
Thank you, Jan. So to the first point around parity, absolutely, I would say this has been a fundamental problem which has now been sadly highlighted by the pandemic. The Queen's Nursing Institute is an organisation that supports nurses who work in the community in a whole variety of different roles, and care homes is one of them. And our nurses work in both residential care homes without nursing and in the nursing home, so across the care sector. And from our perspective, we absolutely understand that far improved parity between both care workers and NHS workers is required to improve the quality of care. Not that the quality of care is good, so it's not to criticise the quality of care, but some of the issues that have already been spoken about, such as the terms and conditions and the access to continuing professional development, and as Nadra said very eloquently, the lack of a career pathway, the lack of regulation of our care workers, that would, if we were able to resolve that, that would certainly resolve some of the parity between our care workers and our NHS workers. And I think that the care home sector is rarely spoken about until we have the coronavirus, and is poorly understood. And I think it's poorly understood amongst our healthcare colleagues as well. And that we see in the community. But it's an area that's a little understood, and in terms of a career pathway, it's little understood for nurses, and we're doing what we can to raise the profile of nurses who work in care homes and the whole of the care sector. It has until recently not had the greatest of profiles. It's had a kind of narrative around it, which is, as a nurse, you go and work in the care sector at the end of your career or when you can't find a job somewhere else. And that has been the most appalling narrative. We have a care home nurses network that we run, and the nurses who work in care homes are some of the most highly skilled, independent, autonomous nurses that you could ever see across the health and social care sector. And what we absolutely need is a system that provides equality for the access to education, equality to continuing professional development, and recognition of those nurses and the care workers to the same level as their NHS colleagues, and clear career pathways. We absolutely support that, because it's the education and training and the standards, the consistency of standards across the education and training for both the nurses and the care workers in the care sector that will provide that underpinning of the quality of care. So absolutely support all of that that's already been said around the career pathways. And I do believe that in England, our new, relatively new, Ruth May, who came into post as the new chief nurse for England last year in January 2019, she has sponsored our care home nurses network. She has come to our events before there was lockdown, and she has said she's doing everything she can to provide equal opportunity to funding for CPD. But the issue of being able to demonstrate parity and the status of the care sector was so spotlighted, highlighted at the start of the pandemic, when care homes were not considered a part of the system, when they didn't get access to the same PPE, and we know that, and Nadra has spoken about that. We know that the transmission from hospital for lack of testing absolutely demonstrated in our report that was published a couple of months ago, demonstrating that care homes were asked to take patients that were or residents that were either testing positive, or there wasn't a status on their COVID-19. So we know that there was a large amount of transmission that way. So again, a kind of disregard for the sector was really symbolic of the disregard for the sector. I do think that there is a question about integration which would help with the parity. And I was fortunate last year to go to New Zealand to look at the integration of health and social care in the community. And I would really commend the system there for the MPC to have a look at that. You probably have, but I did see some and shadowed some of the nurses and care workers and saw a really good system over there. And just to turn, I know I don't have much time, but just to turn to the
1 minute, Crystal.
1 minute, the DNRs. Never have we had at the Q&I such interest in general media from the national media as we had to our report on the experience of care homes during the height of the pandemic. We didn't ask specifically a question about, do you have blanket DNARs in your home, but it's what the respondents said to us. And around 10% told us about that. They said that the DNARs came from, the blanket DNARs came from CCGs and came from GPs. I do think that those are no longer in place. There was a huge response to that. I don't think they're in place anymore, but because of course, our respondents were anonymous, we don't know and can't follow up on those. But we will be following up on further research around to our networks. And the one good thing that has come out of that is that the nurses told us in the response to our survey that they are now having really good and positive conversations about advanced care planning that they might never have had if the pandemic hadn't hit. So there is a good positive that has come out of that. Thank you, Jan.
Okay, thank you, Crystal. That is really helpful. And that answers a question that we had from one of our people on the outside, which was about the human rights of people not being consulted. And obviously we are concerned. We know that there are people with capacity and they can make their own choices if that's an informed choice. We also know that there are people with capacity and have families, without capacity and have families, but our absolute concern is for the thousands of people in care homes and living in their own homes alone without anyone to give them advice and to help them through. So I think that's where we want to concentrate our forces, if you like, in making sure that they have advocates when they are asked about DNAs. Yeah, thank you so much. Right, next on my list is Councillor Karen Kilgour. Karen, are you there?
I am. Hello. Yes, I'm here.
Ah, Karen, hello. How are you doing?
I'm fine, thank you.
Karen is the Cabinet Member for Adult Social Care, Adult Care in Newcastle, and she's been asked to stand in for the Leader of the Council because he's very busy. So your question, Karen, was Newcastle is on the COVID front line right now. What lessons have been learned from the devastation in care homes? How do we make sure it doesn't happen again? And how does a local authority meet the needs of all its people without the proper funding? You've got 5 minutes.
Blimey, that's a question and a half.
It's a question and a half, yeah.
As you know, Newcastle has one of the highest rates of infection in the country so far, so we really are genuinely on the front line currently. To put it in perspective, we've had 137 deaths in care homes between March and the 26th of September, I think. We've learned a lot of lessons along the way. I'll go through them, not in any particular or not in order of importance necessarily. Discharge from hospital was a major one. As we know, as has already been said, people were discharged into care homes without having been tested. Care homes then became effectively an incubator, and some of our most vulnerable residents then became very, very ill. What we did in Newcastle with our partners in health, we commissioned additional COVID secure discharge beds. So it was actually effectively a floor in a care home in Newcastle so that people had a safe, secure, COVID secure space to be discharged into where they would receive proper care and support that they needed until such time that they were able to either move on to the residential care they'd been moved out from initially, move into new residential care, or effectively move home if that was the best pathway for them. Clearly there's a cost associated with that. PPE was a significant challenge for us initially. The national systems were inadequate, chaotic, I think it's fair to say. As a council, we stepped in, we procured our own supplies, we worked with all of the care providers and internally also to make sure that everybody who needed it had the right PPE and also had the right quality of PPE that they needed, because that was a significant challenge, I think, with some of the government systems and some of their procurement. We have enough in the system now, we monitor that weekly. We know that across the system we have enough PPE of the right type, of the right quality. We know now that there are other procurement portals that the government have set up, but also our own internal procurement systems so we can support the care system through that in Newcastle. Testing has been a massive issue, as you would imagine. I've had emails from so many people across the city who have been unable to get a test, who've been sent to Scotland for a test, who've been sent to the south of England for a test. It hasn't been great, particularly when we've actually had testing facilities opened in the city anyway. What we have been able to sort out, however, is routine testing is now in place for care home residents and staff across the city. And we've supplemented that in Newcastle with antibody testing for health and social care staff. And that was carried out throughout August and September in the city. Again, there's a cost associated with that. It's been I think one of the critical things going forward is that we have sufficient testing capacity in the system, but not only that, that we get quick results, and that data is shared with local authorities, where the experts in this, where the best placed people to test it, to do the track and trace, and we can help if we're given the opportunity to. We asked care homes to suspend all but essential visits to reduce infection spread. That has been incredibly challenging for residents and for their families. My dad died in a care home 2 years ago this month, actually, and my heart goes out to people who have been unable to visit their family. It's something we're monitoring on a weekly basis, and hopefully, we'll get to a stage where we can reintroduce those visits. But I do realise how tough that's been for people. We've given financial support to care homes in a number of different ways. We brought forward payments so that they had a cash injection when they needed it right at the beginning of the pandemic. There has been a compensatory increase in rates up till the end of September, and a full cost recovery up to the beginning of September. And that's as well as the government support grant for infection control, which we recently heard has been extended to March next year. Whether those grants are sufficient enough is another matter entirely. One of the biggest areas of lessons learned has been about collaborative working across the health and social care sector. We've worked with partners to provide wraparound support to care homes, putting in place enhanced infection control and PPE, testing, training for staff, step-up, step-down arrangements, use of digital technology. We've had a range of different communication tools. Our commissioning team set up channels of communication, frequent phone calls, weekly emails, briefings, news bulletins. We've provided regular provider meetings and forums, surveys, care and support webpage, frequently asked questions document, and we've shared good practice through that as well to help providers learn from each other where that's been possible. And we've also maintained daily contact with those care homes. But a second wave brings with it new challenges. We know that COVID is in our communities now. So rather than being brought in by people who have been discharged from hospital untested, we know now that COVID is prevalent in our communities. A lot of it's been blamed on young people returning to the city as students. Actually, we know the age is increasing, and there are implications there for our domiciliary care support, for the people who receive that support, but also for the care workers themselves. We know that there's a finite workforce, and we need to support them. We also know that there's fatigue within the workforce, within our volunteers, within the community actually. There are long-term impacts that we are yet to fully understand of COVID. It's created increased demand, not just adult social, well, for all of adult social care, but including mental health. There's loneliness and isolation. There's impact on unpaid carers that we've heard other people talk about. And there's also, it's highlighted the fragility of the care sector. Sorry, I've only got a couple more points. The biggest challenge, obviously, is funding. The council has seen cuts of £327 million since 2010. We've tried to protect our adult social care budgets as best we can, but a 1% increase in council tax in Newcastle brings in £1 million, which is a drop in the ocean compared to the need that we have. So absolutely, we need a proper funding solution. And the government seems to think that adult social care is about discharge from hospital and care homes. Actually, it's about an awful lot more than that. It's about building-based day services, reablement, specialist housing, safeguarding, services for people with learning disabilities and autism, and it goes on. And demand for that hasn't diminished at all. So the real balancing act we have is about, as a council, how do we deliver a whole host of services, not just adult social care, but all of the services that we are expected to deliver. In a time of austerity has not gone away. Not only have we had increased costs, but we haven't been able to achieve savings that we're expected to. We also haven't been able to make the income that we would normally expect from things like car parks. So it's been a triple whammy to our finances. So absolutely, long-term reform with a fair and adequate funding solution is absolutely the answer. Sorry if I've gone over time slightly, John.
Okay, thank you, Karen. Thank you very much. Next on our list, we have Professor Dame June Clark. And June, your question is, Wales has also been at the front line of this pandemic, and Wales doesn't have the social care reform act that England does. It has a different act. Has this made a difference to how care services are structured and delivered, and what can we learn from them? June? Has June disappeared?
No,
Wrong button. Is that better?
Yeah.
Okay. Much of what I would have said has already been said by others, so I won't repeat that. In particular, though, I think the video showed better than any words could what life is like at the real front end. And also, I was particularly grateful for Crystal's remarks on the role of the nurse in the provision of personal care. So I thought I'd do something different, as Jan suggested. I live in Wales. I'm interested in systems. And although we're not perfect by a long chalk in Wales, I think there are things that we've done that have been helpful. And I thought I'd pick out some of those because it may be that there are lessons that other people could learn. There are several differences between Wales and England, and I'll just sort of enumerate what I remember of them and see where we go. The first is devolution, the effect of devolution. And I don't think people outside Wales and perhaps even inside Wales understand what devolution actually means. But it meant that we were able to do things. It means that we have lawmaking powers right across the board now. And it means that, for example, right at the beginning, when everybody could see what was coming, Wales government put in place legislation which laid down conditions about what was mandatory and what wasn't. And that legislation is there and has provided a long-term framework. Another one, the next one, I suppose, is the differences between Wales and England in their culture, which is largely determined by history. Over 200 years, Wales has been much more concerned with collectivism, some would call it socialism, and it has involved much more collaboration and working together. It's meant that, for example, I think the Welsh government, this is only my personal view, got a bit tetchy about the failure of the UK people even to communicate what they were doing with the Welsh people. And Mark Drakeford, in his weekly briefings, noted that it was 3 weeks, he'd been trying for 3 weeks to get a date with Boris Johnson and failing. So, you know, that didn't bode very well. So devolution has got a really important influence. If you look at track and trace, for example, we've had no outsourcing. Track and trace is done by within the NHS systems, and it's concentrated very much, and this is a second important difference, on localism. Whereas the English system seemed to recruit and appoint call handlers, in Wales, the local authorities were involved right from the beginning, and the people that were employed to do the track and trace were local people who knew the area, knew the problems in their area. So that was the second one. The third that goes along with that is that Wales has a long tradition of planning in healthcare. Indeed, one of the things that Mark Drakeford, our First Minister, has said in several ways and several times is that in Wales, we look at the data, we discuss it, we come to an agreement, we make a decision, work out how it's going to be implemented, and then and only then announce it. Whereas England seems to jump, or Boris Johnson anyway, seems to jump in feet first with an announcement or a promise, and then only start to think afterwards about how it could be translated into action. I think our messaging has been much better. It's been honest, it's been clear, the first several times a week and now once a week briefings that the First Minister, our Vaughan Gethin, the Minister for Health, give are straight, honest, precise, clear, and you cannot say that for what the English government has been
You have 1
putting out.
minute.
Okay, so I'd better move on to the priorities question. Very difficult because it's such a mess now. It's difficult to know how to sort it out. The first priority, of course, has to be with supporting the people that are suffering and their carers, treating the disease where it occurs and getting the cases down. That's obviously a short-term priority, but it must be underpinned by long-term planning of a proper system. And how long? It's like waiting for Godot, isn't it? But I'm told that promised paper has been written and is just sitting there waiting to be discussed. Let's get on with that. And whereas we don't want major structural change, nobody does after the last 20 years in the NHS. There are, as I mentioned earlier, several models that could be used. In fact, I think there are two things, good things, that have come out of the COVID mess, and especially the problems in care homes. One is that it actually has put the work of care homes to the top of the agenda in a way that hasn't happened before. As one of the participants in the video said, we were forgotten. And secondly, as I've already mentioned, it has forced different kinds of integration and collaboration, at least at field level. So I think we could be building on that and make, for heaven's sake, let's have a strategic plan into which we can fit the good things we've learned as well as the bad things we've learned. Thank you.
Thanks, June. Moving quickly on now to Mary Robertson. Mary is Senior Policy Officer for the TUC. Hello, Mary. Have we got you?
Hi there. Hello. Yep, I'm here.
Good. Your question is, the TUC's just recently published their own report on care and supports the National Care Service. What do you see as the main impact on those delivering those services under a National Care Service rather than the way that it's done now?
So I think we saw from the video at the start the toll that COVID has taken on care workers. And what we'd want to emphasise is that care workers are, alongside the cared for and unpaid carers, one of the groups who are being desperately let down by the failure to fix the social care system. If we sort of run through quickly some of the conditions that care workers face, more than half of them earn less than the real living wage. Unison have found that over half of councils don't require domiciliary care agencies to pay workers for the time spent travelling between visits. So if you look at their working day as a whole, their pay can often fall below the legal minimum wage. As other panellists have touched on, there's very limited opportunity for pay progression. So if you've got more than 5 years experience in the sector, you'll earn just 15p an hour more than someone who's just started. You know, that's just no way to value people's experience or encourage them to stay and progress in the sector. There's very limited options for training and development. Again, as others have said, care work is a highly skilled profession. It's physically and emotionally challenging, but that's just not recognised at the moment. Work in the care sector is currently very insecure. Almost 1/4 of care workers are on 0 hours contracts. We've got a really high level of shortages, so approximately, over 120,000 vacancies in the care sector at the moment, and the turnover rate of over 30%. And that's going to feed into the kind of level of care that the system is able to provide. And it's also highly fragmented. So I think there's over 18,000 organisations in providing care across over 38,000 establishments. You know, that means it's difficult for care workers to raise concerns. Care worker voice just disappears from the equation. We've also seen through the COVID crisis how difficult that fragmentation has made it to implement change rapidly through the system and to respond to issues as they emerge. And finally, before moving on to kind of what we think needs to be done, just more anecdotal illustration of the kind of lack of value of respect with which care workers are treated. So the government set up an infection control fund to try and reduce the spread of COVID in care homes. One of its intended purposes is to give staff full pay when they have symptoms or when they're advised to isolate, because the low pay of care workers meant that a lot of them were facing the choice between being able to put food on the table and being able to follow government guidance on isolating. One of the problem is that we've had reports back from members that this infection control fund is often not getting through to care workers, and in some cases that's because management of care homes are reporting that they don't trust their staff enough to come to, they're not telling their staff that this money is available because they don't trust them to come to work. So it's just a huge, if you look at the kind of the way in which care workers have gone above and beyond to keep the care system going during this crisis, and that's contrast that with that kind of attitude from at least some managers, I think it really gets to the heart of the lack of value and respect with which care workers are treated. And, you know, the bottom line is you can't have a high quality care system without a workforce that's valued, respected and treated well. That has to be at the absolute heart of it. So in terms of what we think needs to change, what needs to be the impact of a national care service on care workers, first, very simple, improving pay and conditions. We're arguing to raise pay of care workers to at least £10 an hour, get rid of 0 hours contracts and ensure that all care workers receive proper sick pay. So when they're unwell or when they need to isolate, they can afford to not come into work. And you know, frankly, you won't get people wanting to join and stay in the sector until that changes. There is a fear, I think, that we've got rising unemployment because of the economic impact of the lockdown, and that we fear a presumption among ministers that there'll be so many people looking for work that without improving conditions in the care sector we'll be able to recruit more people. You know, but we need to think about longevity as well as immediately filling roles. And if we want people to stay, build up their skills, and progress in the sector, you need good paying conditions.
Mary, you're nearly at 5 minutes.
Okay, so 3 more things really quickly. First, fill their 120,000 vacancies and recruit to meet expanding need, and that recruitment to meet expanding need is really important. Demand for care is going to grow, and you know, if we get this right, care can be a source of good jobs right across the country. Third, mentioned already, the complex physical and emotional skills care workers deploy every day. We need more opportunities for career progression through formal skills accreditation and training, and also through national pay structures. I think David mentions that the care workforce isn't included in the NHS People's Plan. We need an equivalent in the care sector. And finally, relatedly, a national social care forum that brings together government, unions, employers, commissioners and providers to coordinate the delivery and development of services, including negotiation of workforce strategy and giving the workforce a voice in shaping delivery.
Okay,
and I'll stop there. Thank you.
Thank you very much, Mary. We're really getting pushed for time now. We're nearly out of time, actually, but we'll carry on while we've still got people here. Our next speaker is Dr. Aaron Baxi, who is a consultant in the Isle of Wight. Dr. Baxi, your question is, what is your experience as a physician of the imbalance between the NHS and the care sector? You've got 5 minutes.
Thank you very much, Jan. It's a privilege to be able to listen to such moving and thoughtful comments of previous speakers. This is one of the advantages of being one of the last speakers, but the disadvantages of most of the things that I was going to say have already been said. And so I shall refrain from repetition as far as I can help it. Now, it's surprising that the coronavirus pandemic has thrown into sharp contrast the damage caused by the divisions between health and social services. I wonder why it's taken this to happen, because for many years, every winter, we have a crisis. Similar, not very dissimilar from the coronavirus effects. And yet, society has done nothing. Successive governments have really tinkered with things. Governments have actually, I have worked in the NHS now since 1962 till the end of February this year. And what is amazing is how many dramatic changes have affected NHS and social care. Now, the seeds of this division were sown at the very outset of the NHS, when the NHS was made separate from social care, which was given to local authorities. Since then, successive changes have actually increased the divisions between sectors. It has destroyed the relationship between hospital and primary care, and you saw what happened in this pandemic because of that. It has separated social care, remains highlighted this. Now, why? Because we are talking as if a patient is admitted to hospital, goes to social care, and that's the end of the story. It's not. It's that individual will actually go through similar phases throughout their life. So what we have to have a system where an individual, when required, goes to the hospital, when required, goes to the social care sector, and when necessary, comes back. If you need rehabilitation, they go to. Now, because of rehabilitation services and most services are hospital-based, this doesn't happen. Now, my question is this. We know what has happened as a result of the divisions. How long are we going to carry on with this sort of effect? Now, you said there are certain, I heard one of your speakers say there are areas where integration is working. Well, it depends on what you mean. I mean, the CQC did a survey in 2018. They surveyed 20 districts with so-called integrated services, and they concluded not one had actually got anywhere near that. And I don't think it will happen. Integration cannot happen till we actually bring together the services that are going to affect an individual throughout one's life. I'm talking about, if you like, cradle to the grave. There is no difference. And the injustices that occur, that we see, are because of the failure of society to accept that service is from the beginning to the end. All of us will need. Now, I feel very strongly, and the closer you get to old age, the more critical one feels about this. Now, I'm 82, and I feel very strongly that the time has come for real change to take place, where hospital care, primary care, community and social care will come under one unit funded by general taxation. But importantly, it will be governed by a local care authority that will respond to local needs. This will actually stop the turf warfare that we see goes on every year for more money. There is no doubt in my mind that without a good social care, NHS will not become a sustainable system. Because where you just think about that, an elderly person who cannot afford to stay in a home, he hasn't got a home, where will he or she end up? In the hospital. Like we come back to the critical crisis we face every year. It is time that we face it. And in fact, the recent BMA survey of GPs showed that over 70% of GPs wanted integration with hospital care. Now, I will just finish very quickly by quoting you. There was a Mori poll which was conducted just before the Brexit. And the vast majority of people who voted rated social care as number 3 after NHS. First was let me just get this right. I'm just looking at it. Brexit was number 1, NHS was number 2, and a close third was social care, way ahead of economy, education, and everything. And I think the time is actually right for us to ask for a change. Now, one of your speakers said, we can't have a wholesale change. That begs the question, what do you mean by wholesale? Can there be a more wholesale change than the 2012 Act? That was a massive. 2009, with the internal market, these were massive. Well, we shouldered all that. And I think we can shoulder yet another studied, executed national care service. And finally, I end with the statement that in a recent forward to a journal from Policy Exchange, Jacob Rees-Mogg made this comment that, and this is only last year, he said, every member of parliament will be aware of the deep unfairness inherent in the country's health and social care provisions. And I suggest to you that what you are doing is absolutely correct. And I will fight for that for as long as I can. Thank you for inviting me, Jan. I hope I will be able to continue serving this country I love.
Well, most definitely. Thank you, Dr. Baxi. Right. We have run out of time. So what I'd like to do is, we've had lots of comments, some about lobbying, some questions. What I'd like to do is make sure that we capture these, Jonathan, and we will put them on our website. But those that are our questions that we can direct maybe to the panel of speakers by email and get a response, and then we will respond to the person that sent that question. What this has taught us, I think, today is that we either need longer on a webinar like this, because it is such a passionate and involved conversation that we've had today, or we have less speakers, but we will sort that out for the next one. It has been good. I'm absolutely convinced now that what the NPC is doing is right. We need other people to come on board, and I wanted to go now to the very short poll question that we have. Should the government engage in an honest, open debate with all stakeholders on the feasibility of a national care service as part of its reform of the care sector? And if you could vote now, please. And whilst Jonathan is making collecting all the votes, could I go back to David and Jean to do a very quick kind of summary of what has happened today? David, can I go to you first?
Okay, yeah, I'll be quick. Yeah. Obviously, I've read the report more than once because I wrote the foreword to it, and I think it is a fantastically well evidenced and well referenced and clearly written plea for lasting solutions. The time is right, and I think the obviously the economic considerations around funding have been thrown into disarray because of the pandemic. But if you look at what the three main health think tanks are arguing, or other lobbying groups, like Socialist Healthcare Association or Keep On NHS Public, or what some of the key reports like the Barker Commission from the King's Fund or DILNOT recommended, they're all setting out, give or take, a similar set of challenges and a similar set of solutions. So I think there's more agreement than there is disagreement. And what we need is concerted lobbying with a single voice. Even NHS organisations like Royal Colleges and the Confederation are saying that social care has to be the priority at the moment. And so I commend the recommendations in the report, and I hope it's listened to. And I'm sorry that so few influential politicians were able to attend today, but don't give up the lobbying. And I'm happy to try and answer some of the questions that were coming through offline, or set up another Q&A if people want to just do a session trying to go through them all. Thank you.
Thank you, David. Jean, last 1 minute.
Yes, about 10 years ago, locally here at least, there was a really good attempt at integration stroke cooperation, where all the stakeholders would meet together, including social care, including people who were involved in care like myself, the patient themselves, and the professional healthcare workers. And it worked so brilliantly all together in the one room and sorting out what exactly was needed for the patient pathway. And I don't know what happened to that initiative, whether it was just underfunded or was stopped, but that is such a brilliant way to go. It makes such a difference to the patient and the patient's carers, both formal and informal. And I think we're all on the same page as regards privatisation and the other issues around it. We really need to work together to ensure that something happens around this and that our thoughts are taken up.
Thank you, Jean. Results of the poll, Jonathan? Oh, well, there you go. We're on the right track. So that is brilliant. And yeah, just taking on the point from Jean, yeah, we need to move forward with lots of other people. Our voice alone is not going to make a difference. And I'm just going to sum up now, and I want to thank everybody that has taken part in this for their time, their contributions. It's been amazing, the level of contributions that we've had from all of you. So I do thank you for making the time to take part in this. What I'd ask you to do is promote our Goodbye Cinderella document amongst the people that you know. Get your people, particularly from the TUC, to get ordinary members of the public to view the webinar on YouTube. It's been recorded, because generally the public has no understanding of the crisis in social care until it sits on their front door and knocks on their door. And then we get people saying, you didn't tell us this. Well, we've been telling you it for the last 20 years. Yeah. So anything you can do that promotes the webinar, there will be more. If you know of people that would be interested in either watching or being part of the next webinar, they'll all be different. There'll be different panel members and different audiences and different parts of our Cinderella document being taken out on there. Finally, we will email you a feedback survey. Please complete it honestly, as we can only improve the work that we do by listening and taking on board your opinions. And I think today has given us some really good lessons to follow. One of the things that Jean put in her chat was that she wanted people to know that Uzbekistan takes care of their people in hospital and in social care far better than we do. And if you look at Uzbekistan and their economy, you ask for us, the English Parliament, why? So this is not over. This is the very first step. And once again, thank you. And I hope that you enjoyed it and we've all got something really, really good out of it. I know I have. So for now, until the next time, thank you. And thank you so much.
Thank you for organising this.
Yeah, that's okay.
Just forgot to mention, Jan, that I would be very happy to send the paper through to you for distribution if you like.
Yes, of course you do that. Yeah, we'll be happy to help you.
Okay, thank you all. I'll end the webinar and I'll get notes and slides and the link, should people want to watch it, sent out to our members. Okay, thank you all.
Okay, thank you, Jonathan.